Welcome to set 1 of our internal medicine review questions. This will be a set of 10 questions to help guide you through some USMLE style questions that may come up on the exam. If you haven't already, to help keep these videos free, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. If you could just consider chipping in $1 a month, a little bit goes a long way. If you like these videos and want to see more of them, you can go ahead and sign up at my Patreon page. If you chip in $1 a month, you'll have access to some premium videos in which I go over case studies, formulating a differential diagnosis, and treatment plan, things that will come in handy for you as you gear up to study for the exam. Question number 1 gives us a 21-year-old woman presenting to your clinic complaining of malaise and left hand and finger pain for the last 3 days. She is generally in good health. Medications include drospirenone ethinyl estradiol, which is an oral contraceptive. She is a junior in college and works part-time as a veterinary assistant. She denies smoking, drinking, and illicit drug use. She's sexually active but monogamous with her boyfriend of 8 months, but admits that they use condoms inconsistently. She denies trauma to the affected hand. Vitals are 115/70, heart rate 115, respirations 14, temperature 100.9 degrees, saturation 98%. Physical exam is remarkable for red, swollen, tender digits on her left hand, along with small papules and vesicles on the dorsum of the hand and webs of the fingers. Labs give us a hemoglobin of 12.1, hematocrit 38, white blood cell count of 13.1 with 90% neutrophils, platelets 255, SED rate of 45%, and her BMP is unremarkable. Which of the following is the best next test to confirm the diagnosis in this patient? Is it A, synovial fluid gram stain, B, synovial fluid cell count, C, x-ray of the left hand, D, peripheral blood cultures, or E, cervical, rectal, throat, and blood cultures? So as always, I will give you a chance to pause the video to come up with a response. And the answer to this question is E, cervical, rectal, throat, and blood cultures. Now, we have a patient here who has some degree of possibly joint pain or some kind of skeletal issue going on, rheumatologic issue going on, in conjunction with a fever. Now, anytime you have that, you may think of septic arthritis. Now, we don't know if this patient has septic arthritis or not because we don't know to what degree this is actually centered on a joint. And in fact, this patient probably has tenosynovitis, which is actually inflammation along the tendons and around the joint area, but not necessarily in the joint fluid itself. So anytime you have a patient who is younger and has these kinds of symptoms that are consistent with tenosynovitis, or if they have septic arthritis, for instance, arthritic symptoms that are acute and accompanied with a fever, the first thing that you need to think of is septic arthritis. And when it's in a young patient, the most common cause of septic arthritis is gonococcal. And so we need to determine, in order to treat this patient properly, we need to determine what the cause is, what the actual microbiological agent is behind this disorder. Because we know she has joint pain, we know she has tendon issues, but we don't know what the cause is, and our management of this patient is going to be antibiotics. And so in order to give her the proper antibiotics, we need to know what the pathogen is. And since we know that it's probably gonorrhea, we're going to do tests for gonorrhea. And that would be cervical, rectal, throat, and blood cultures, which is something that you want to get anytime you suspect a disseminated gonococcal infection. Now, if she only had cervicitis or something like that, then you could just do cervical cultures. You wouldn't need to do blood cultures. So why would we not want to get a synovial fluid gram stain here? The reason we wouldn't go after the synovial fluid in this patient is because there's no particularly affected joint. Now, if she came in with a big swollen knee, then a synovial fluid gram stain may be appropriate. But do keep in mind that even in patients with septic arthritis, a gram stain is only going to be positive in about 50% of patients with gonococcal septic arthritis. A synovial fluid cell count would be helpful for the diagnosis of septic arthritis if we suspected that to be the case, but it would not tell us the cause. So you'd have elevated white count, well, that's great, but it doesn't tell you the cause. And we need to know the cause. Knowing septic arthritis, that's fine, but if you don't know if this is Staph aureus or if this is gonorrhea, it's not going to help you with optimal management. X-ray of the left hand isn't going to give us any specific findings other than maybe some soft tissue inflammation, so that's not going to be helpful. That would be more helpful in the setting of trauma. Peripheral blood cultures, even though this is probably disseminated gonococcal infection, it's only going to be positive in about 40% of patients. Now, we are going to get blood cultures, but we need to get cultures elsewhere. And it's going to be the cervix that's actually going to be most useful because that's where the gonorrhea is going to be. Now, not all patients with cervical gonorrhea are going to actually have cervicitis or symptomatic cervicitis, but they still will likely have positive cervical cultures. And so the answer to this question is to get cervical, rectal, throat, and blood cultures. Nail down the diagnosis of gonorrhea. When it's in conjunction with this patient's symptoms, we can diagnose her with a tenosynovitis, which is related to gonorrhea. Now, the fact that she is monogamous with her boyfriend is fine, but we don't know if the boyfriend is monogamous with her. So you can never just base a possible STD history on a patient by their monogaminity, to make up a term here. You have to understand that there's a possibility that the partner is not monogamous, or possibly that the partner carries the pathogen, especially if we're talking about chlamydia here. Gonorrhea a little bit different, but the possibility that the partner carries it. Okay? So this is disseminated gonococcal infection. In about 60% of patients, it's going to present as the bacteremic form. The bacteremic form commonly presents as tenosynovitis, but there's a typical triad for the classic disseminated gonococcal infection, and that's skin lesions, polyarthralgia, and tenosynovitis. Now, the other 40% of patients will present with actual septic arthritis, which tends to affect either one joint or a few joints, and they also tend to be bigger joints. This, regardless of what form you have, and one can lead into the other, the presentation is going to be asymmetrical. So you're not going to have both hands affected or both knees affected. It's going to be asymmetrical. With the bacteremic form, tenosynovitis is usually the initial manifestation, often affects smaller joints, the fingers, the dorsum of the hand, the wrists, and in most cases you're also going to have a rash. We call this the arthritis dermatitis syndrome, where you have a triad of a rash, tenosynovitis, and polyarthralgia. The rash in this patient was a combination of papular lesions. They can also have some blisters and pustules as well. Septic arthritis can be mono or polyarticular. Better word would be pauciarticular, meaning few joints, and presents as erythematous, warm, swollen, and painful joint with limited range of motion. If this were limited to one joint, like just the knee, you could get a gram stain of the synovial fluid, but it's not really going to be terribly helpful if we're suspecting gonococcal infection, because as mentioned, it's only positive in about 50% of patients. So we really want to go after where you're going to have more sensitivity, and that's going to be in the cervix in this patient. If it were a male patient, you could go after the rectum, throat, and obviously we're always going to get blood cultures too. Of course, this is going to present with systemic signs because this is a systemic infection, and so you can have fever, malaise, and chills. As we had in this patient, we had fever and malaise. The treatment for disseminated gonococcal infection is going to be ceftriaxone, either intramuscularly or intravenously, 1 gram per day for 1 week, and azithromycin, 1 gram orally just once. And I said intramuscularly or intravenously. This patient may have to be admitted depending on the severity or whether or not you're able to nail down the diagnosis. Okay? Some of the differentials here include non-gonococcal septic arthritis, but because this patient is younger, has a history of unprotected sex, this is more than likely gonococcal infection. Gout would be another differential if this patient were older, male, but gout is also not commonly polyarticular. You'd also probably not get a rash with gout. We would also, in the long term, want to test this patient for other STDs. Just part of good management for a patient who's diagnosed with one STD. You want to test them for other STDs as well. Question 2 gives us a 24-year-old male who's been rushed to the ED after collapsing during a recreational basketball game. According to his electronic medical record, he has no significant past medical history aside from an appendectomy at age 18 and has been in excellent health and saw his physician regularly for annual physical exams. Family history is significant for a heart attack in his father at age 44. Despite all attempts to revive him, he's pronounced dead 15 minutes after arrival. Which of the following is the most likely cause of death in this patient? A. Ruptured aortic aneurysm. B. Myocardial infarction associated with FH. Familial hypercholesterolemia. C. Hypertrophic obstructive cardiomyopathy. D. Aortic stenosis. Or E. Aortic dissection. And the answer to this question is C. Hypertrophic obstructive cardiomyopathy, or HOCM, H-O-C-M. So we have here a patient who is young and happened to collapse and go into what is likely an arrhythmia and sudden cardiac death. This is not something that we commonly see in younger people. And it's worth noting that if you have a patient who is young and has sudden cardiac death, that the #1 cause of sudden cardiac death in young patients is going to be hypertrophic obstructive cardiomyopathy. Now, what's happening here is that you have you have an outlet obstruction of the left ventricle, which is going to result ultimately in expansion of the left ventricle, and that's going to cause an arrhythmia, which is going to be ventricular fibrillation. So why not A? So ruptured aortic aneurysm. Well, first of all, ruptured aortic aneurysms, it does cause sudden death, but it's very rare in patients under the age of 60, much less a 24-year-old guy who's otherwise healthy. Then why not B? So with B, myocardial infarction is a possibility because his father was 44, but even with heterozygous FH, typically the symptoms don't begin to manifest until late 30s, early 40s at the earliest. So age 24, not likely to be having symptoms of FH. Now you have to always consider that possibility in this patient, and were he alive and coming in for physical examination, you definitely want to check his cholesterol levels because it's not common to have a heart attack in age 44 like his father did. And so while this patient may have FH, it's highly unlikely that he actually had a heart attack because, as I mentioned, heterozygous FH typically does not manifest until late 4th, early 5th decade of life. He may have very high cholesterol levels, but it's not going to cause a heart attack at his age, not just yet. We don't even know if he has FH, but it is a possibility given his family history. Now, homozygous FH is going to present much, much earlier. It would present in early childhood. He would not go to age 24 without having symptoms. And then aortic stenosis, it is a very common valvular disease, but it's also not seen in young patients normally. So this is something that's typically seen in elderly patients. It's associated with advanced age, also associated with rheumatic disease, but rheumatic disease is not common in the United States. And so because this disorder is so uncommon among younger patients, it's unlikely in this patient. And then aortic dissection, again, another disease common in older patients, but not seen in otherwise healthy young guys. So also with aortic dissection, there's typically a history of hypertension, and this guy doesn't have that either. So A, D, and E are all possibilities if the patient were much older. B would be a possibility if he was a little bit older, but we don't even know if he has FH. So C would make the most sense, and this is what you want to answer when you have a patient with sudden cardiac death who's in their 20s or teens. Okay, this is something that happens to younger people. So hypertrophic obstructive cardiomyopathy is relatively common, but it's underdiagnosed because the only way you're going to be able to tell if the patient has it is if they have symptoms, which they don't always do, or if you screen it, or if you do like an echocardiogram and you happen to find it coincidentally. So 1 in 500 people in the US, relatively common. It is, in many cases, a familial disorder, so his father may have had it. And it's inherited in an autosomal dominant pattern. The mutation itself causes a defect in some of the proteins that make up the myocardium, which ultimately is going to result in dysfunction of the myocardium, namely fibrosis and hypertrophy. And as that myocardium thickens, as you can see here, as it thickens, the ventricle does not increase in size. And this results in diastolic dysfunction, which gives rise to some of the symptoms like dyspnea, syncope, presyncope, as well as palpitations and angina. But not all patients will have those symptoms. Unfortunately, sometimes the more common presenting symptom is sudden death. So another thing that happens, which is very problematic and probably led to this patient's death, was outflow obstruction. And so what happens is the intraventricular septum here, it enlarges and blocks the outflow from the left ventricle to the aorta. On physical exam, you will probably hear a systolic ejection murmur, provided the patient's alive, of course, and that ejection murmur will be diminished with Valsalva. The treatment is to avoid strenuous exercise, reduce the demand on the heart, and to keep hydrated. You want to keep hydrated because volume depletion will increase the pressure gradient across the left ventricular outflow tract. The treatment for hypertrophic obstructive cardiomyopathy is, alongside avoiding strenuous activity and remaining hydrated, is beta blockers. So something like Inderal, which will manage the angina and the dyspnea. Calcium channel blockers are also often used, but they're second-line agents and typically used for patients who are refractory to beta blockers. Okay, question 3 gives us a 43-year-old man presenting to the ED who complains of left-sided flank pain over the last 6 hours. He rates the pain as a +7 out of 10 and describes it as sharp and radiates down the lower back. He has tried acetaminophen, but this did not help. He has a past medical history of hypertension for the last 8 years, which has been treated with lisinopril hydrochlorothiazide. Vitals 140/100, heart rate 110, respirations 12, temperature 97.5, saturation 100%. Physical is significant for right-sided CVA tenderness and bilateral renomegaly. CBC and CMP are unremarkable. Urinalysis is significant for 1+ RBCs. Which of the following is the best next step in the management of this patient? A, renal ultrasound, B, renal biopsy, C, MRI, D, CT abdomen, or E, intravenous pyelography? Okay, and the answer to this one is A, renal ultrasound. So here we have a presumptive diagnosis of what? Autosomal dominant polycystic kidney disease, which should always be suspected when you have a middle-aged person who has a triad of hypertension, microhematuria, and the big one here, palpable kidneys, bilateral renomegaly. So B, renal biopsy, we don't want to do that because it's invasive. And it's not going to provide us any more information than imaging. So we know we need to do imaging here because if we suspect autosomal dominant polycystic kidney disease, then we're going to be able to see that on imaging. So the question is, what kind of imaging? We don't want to do a renal biopsy because, yeah, you'll be able to diagnose it on pathology, but it's not going to tell you anything that imaging can't tell you. So no renal biopsy for this patient. You have risk of infection and trauma, you just don't want to do that. MRI is certainly the most sensitive imaging test, but it's very expensive and it's really not that much more effective in making a diagnosis than an ultrasound would be. Likewise with CT, it's also more sensitive, but it also would expose the patient to iodizing radiation, and we also don't want to do that either. And then E, intravenous pyelography, that used to be used for the diagnosis of autosomal dominant polycystic kidney disease, but it's been abandoned mostly because it has less sensitivity than ultrasound, especially in the early stages of ADPKD. And it also exposes the patient to contrast medium. And some of these patients may be borderline renal failure, and so we want to avoid that if at all possible. So renal ultrasound, these kidneys are very easy it's very easy to find the abnormality by doing an ultrasound. You'll be able to see big, massive cysts in most of these patients. Autosomal dominant polycystic kidney disease is a multisystemic and progressive disorder which is characterized by the formation of cysts which form on the kidneys, but they can also form on other organs, including the liver, pancreas, and spleen. Important to recognize that the adult form, autosomal dominant, versus the pediatric form, which is autosomal recessive and totally different. The adult form is asymptomatic until middle age. They may have cysts, but they're not going to be symptomatic until they hit middle age. So it makes sense that this patient doesn't have any history of being diagnosed with polycystic kidney disease. The most common presenting symptoms are typically related directly to the cysts. The cysts themselves can cause pain. They can also rupture or become secondarily infected, and that can cause pain. You can also get some bleeding from the cysts, which can result in microhematuria, or it can result in a gross hematuria. Okay, but either way, hematuria is going to be one of the things that we look for with autosomal dominant polycystic kidney disease. But the big ones here are pain and obviously the palpable kidneys. These kidneys become quite large, so it's kind of difficult to tell with this picture. But this kidney is way bigger than it should be. It should only be maybe about half this size, but there's nothing to show you the scale here. For diagnosing ADPKD, what we do is we get an ultrasound. That's going to show us the cysts, and that's quite specific for ADPKD. If on the test you were to get autosomal recessive polycystic kidney disease as a possibility, just know that that is not a diagnosis that's made in adulthood. Autosomal recessive polycystic kidney disease is a diagnosis of pediatrics. It presents in childhood. It's much more rare, but also much more severe. The treatment for ADPKD is to prevent complications. Those complications can include urinary tract infection. Also, the very, very, very big complication that's associated with ADPKD is, this is very high yield, severe headache in a patient with ADPKD. If it's already been diagnosed and you have this patient coming in with severe headache, ruptured berry aneurysm causing a subarachnoid hemorrhage. So you want to understand that this is a complication of ADPKD. A lot of these patients with ADPKD will get screened for intracranial aneurysm. So particularly patients who are going to be having surgery, any patient with ADPKD who comes in with neurologic symptoms, or patients who are at risk of putting others in danger if they were to have a ruptured aneurysm. So one occupation that jumps to mind right away would be somebody like a commercial pilot. In that case, if they were to have a ruptured aneurysm, it would certainly put a lot of people at risk. There goes my dog. Sorry about that. Okay, so that's important to keep in mind as well. All right. Question 4 gives us a 30-year-old woman presenting to the clinic with her husband because of irregular movements of her upper extremities and behavioral changes over the last 6 months. The husband says that that her personality has changed considerably over the last several months, and she's lost interest in things that she normally enjoyed. She's become much more disagreeable and anxious lately, and has recently quit her job as an accountant because she is unable to concentrate. Her mother died at age 52 due to what was described as quote-unquote early onset Alzheimer's, and her maternal grandfather, her mom's dad, died at age 65 after having been committed to a psychiatric unit. Patient has otherwise been in good health and has no previous psychiatric history. Vital signs are within normal limits. Physical exam is remarkable for erratic, spontaneous flinging movements of the upper extremities. No other neurologic abnormalities are present. Mental status is intact, but there is decreased concentration. Which of the following is the most likely diagnosis in this patient? A. Tourette's syndrome, B. tardive dyskinesia, C. Parkinson's disease, D. Huntington's disease, E. Creutzfeldt-Jakob disease, or F. frontotemporal dementia, otherwise known as Pick's disease. Okay, the answer to this question, hopefully my dog doesn't start barking, is D. Huntington's disease. So Huntington's disease is quite rare, but you should know it when you see it. Okay, so Huntington's disease is going to be associated with two things that we see in this patient, and they're very important to pick out because you will get a question on this on the USMLE, I can almost guarantee you. So first off, it's these abnormal movements. So Huntington's disease is a movement disorder similar to Parkinson's disease. However, the movement issues are unlike Parkinson's, where it's more rigidity and slowing of movements, the bradykinesia. With Huntington's disease, it's more of this chorea. Chorea, remember, comes from the Greek word for dance, and that's kind of how it's like. As they walk, they have these sort of purposeless movements, especially of their upper extremities. So it kind of looks like they're dancing as they move about, and that can also happen when they're sitting still as well. It looks like purposeless movements. Now, what also shows up with purposeless movements? That would be tardive dyskinesia. But this is not tardive dyskinesia because tardive dyskinesia is associated with the use of antipsychotics, long-term use of antipsychotics, and we don't see that in this patient. Now, the other thing that is associated with Huntington's disease is behavioral changes. And typically those behavioral changes begin as sort of irritability, maybe fidgetiness, although that can be more related to the chorea as well. But then they begin to develop moodiness and antisocial behavior. Ultimately, they progress into total dementia. So those two things, the movement symptoms and the behavioral changes, especially, and this is critical, with a family history of dementia or similar issues occurring at a relatively young age. And what's going to be useful here, and you don't always see it, but what's useful if you see it on the USMLE, it will be a dead giveaway, is that you have this phenomenon known as anticipation, which means that it occurs at an earlier age in each subsequent generation. So grandpa died at 65, mom died at 52, now this patient is 30 and developing similar movement, dementia, cognitive behavioral signs. So Huntington's disease is a rare inherited disease which involves atrophy to the caudate nucleus and to the putamen, which results in the characteristic movement signs. As those regions of the brain atrophy, it causes the lateral ventricles to enlarge. It's not that the ventricles are getting bigger, it's the areas around it are atrophying, and so the ventricles are going to appear larger. The characteristic signs of Huntington's disease are the chorea, which is purposeless, involuntary dance-like movements, as well as the cognitive and behavioral signs. Going back here, so why is this not Tourette's syndrome? Tourette's syndrome typically is diagnosed in childhood. It's also characterized by sort of motor tics, but it's not characterized by sudden behavioral changes. There are behavioral issues in Tourette's, particularly ADHD, but not sudden behavioral changes, and certainly not sudden behavioral changes in a grown-up. Tardive dyskinesia, we already talked about. Parkinson's disease, that's also a movement disorder, but it's going to be things more like resting tremor, rigidity, bradykinesia, not going to be things like chorea, which is what we see in this patient, or balismus, which is sort of low-frequency, large flailing movements of especially of the upper extremities. Kind of like if you tap the knee with you're doing a deep tendon reflex. It's like something like that happens with their extremity, but you're not doing anything to elicit it. That's kind of balismus in a nutshell. Parkinson's disease is also not associated with behavioral changes early in its manifestation, and there's also not an obvious inheritance pattern. Creutzfeldt-Jakob disease is a prion disease. It's extremely rare. It manifests as a subacute dementia, usually over the course of months. There are also movement signs like ataxia and myoclonic jerks, but it is not a congenital disorder, and cognitive decline is quite dramatic. So this patient does not have dementia. There's just some issues with concentration. With Creutzfeldt-Jakob disease, over the course of 6 months, she would go from totally normal to totally demented. So we don't see that in this patient. And given the family history, it's more consistent with Huntington's. And then finally, frontotemporal dementia or Pick's disease. That also results in behavioral changes, but does not appear to have a genetic predisposition. There may be movement signs in Pick's disease, but they're not prominent. Pick's disease is more common than Huntington's by far, but when you see a clear autosomal dominant inheritance pattern, it's going to have full penetrance, you should really think Huntington's disease. Huntington's disease is not very common, but you'll see it in little patches in different parts of the country because of the genetic predisposition. Not too long ago, I was working out in an area in rural Minnesota, population size only about 20,000 in this city, happened to have 3 or 4 people with Huntington's disease, all in the same family. So the median survival for Huntington's disease is 20 years after the onset of symptoms. Prognosis is quite poor. There's really no cure. Disease progression can't be halted. So really the treatment is only symptomatic. You can use reserpine or tetrabenzene for movement signs. The psychosis that invariably is going to result from Huntington's at some point can be treated with atypical antipsychotics, but you have to use caution with those because they can increase the risk for extrapyramidal effects or tardive dyskinesia, which we don't want to see. Usually we can work around that by using the atypicals and not things like Haldol. Genetic counseling is good for offspring, potentially affected relatives like siblings, and depression is a possibility in these patients, as it is with a lot of patients who have dementia, but these patients are also at risk for depression just because of the prognosis of their disorder. And so SSRIs are going to be first line, as it is in most depression. Okay, question 5 gives us a 37-year-old man presenting to the clinic complaining of weakness over the last 2 months. He says that yesterday morning after he woke up, he lost his balance when he stood up and fell down. He denies any significant trauma. His medications include albuterol for asthma and simvastatin for dyslipidemia. He denies alcohol, smoking, and drug use. He says that he has lost about 10 pounds over the last couple months, and he has had intermittent diarrhea and general loss of appetite. Vitals are stable, but orthostatic hypotension was noted by your very intelligent nurse. Physical exam reveals random patches of depigmentation and relatively pigmented regions on the knees and knuckles. Finger stick hemoglobin is normal. Which of the following is the most likely cause of this patient's symptoms? Is it A, excess adrenal production of aldosterone, B, autoimmune destruction of the adrenals, C, autoimmune destruction of the thyroid, D, autoimmune stimulation of the thyroid, or E, cortisol secreting pituitary adenoma? Okay, the answer here is B, autoimmune destruction of the adrenals. Now this is a very classic style of USMLE question in which they give you everything and you know what the disease is, and then you get to the answer choices and it expects you to know the mechanism of the disease. Now this is a relatively straightforward one. So this patient clearly has signs of adrenal insufficiency. Okay, he's got diarrhea, loss of appetite, weight loss, hypotension, and then, of course, what's classic with this disease in particular is this depigmentation-pigmentation pattern. This patient has a presumptive diagnosis of Addison's disease. Addison's disease is going to manifest typically with adrenal insufficiency, but you'll have that added hint, at least on USMLE questions, you'll have that hint with the pigmentation. This is a white, normally pale-skinned patient who now has what appears to be a perpetual suntan. Okay, that's just a classic dead giveaway of Addison's disease. In real life, Most patients with Addison's disease don't have anything that obvious. However, because these patients with Addison's have an autoimmune process, they're at risk of developing vitiligo, and many of these patients actually do. So you may see regions of depigmentation, which may be in conjunction with regions of hyperpigmentation. So going down our answer choices here, excess adrenal production of aldosterone, what's that called? That's called Conn syndrome, and so that would be sort of the opposite of what we've got here. Conn syndrome, we don't see it very often because it's pretty much scantily symptomatic. Doesn't really show up with a whole lot of symptoms. It may be manifested with a high blood pressure or muscle weakness. Because you have high levels of aldosterone, you're going to have a hypokalemia, which is the exact opposite of what you would have with Addison's, where you would have a hyponatremia and a hyperkalemia. With Conn's, hyperpigmentation and vitiligo are not going to be present. C, autoimmune destruction of the thyroid. What's that? That's Hashimoto's thyroiditis, and it is the most common cause of hypothyroidism and will result in cold intolerance, goiter, weight gain, and sparse hair. Absolutely not any of those things we see in this patient. D could be confused here. Autoimmune stimulation of the thyroid, what is that? That's Graves' disease. So Graves' disease also results in weight loss and occasionally can have diarrhea as well, but you'll see some other symptoms like heat intolerance, tachycardia, tremor, difficulty sleeping, which we don't see in this patient. He's more fatigued. And then the big one with Graves' disease is that weight loss will be in conjunction with an increased appetite, whereas with Addison's disease, it'll be weight loss in conjunction with a decreased appetite. And then finally, E, cortisol-secreting pituitary adenoma. What's that? That's Cushing's disease. And that's going to result in a weight gain. So that's not what we have here, obviously. So Addison's disease, autoimmune destruction of the adrenal glands. You see hyperpigmentation and vitiligo in some patients. The symptoms are weakness, fatigue, anorexia with weight loss, hypotension, either general or orthostatic, depending on how severe it is. So when you have volume depletion, orthostatic hypotension is always a possibility. These patients can be mildly volume depleted because of their hyponatremia. Salt craving is a classic symptom of Addison's disease. Don't expect to see that on the USMLE because it's such a dead giveaway, but it's good to know. Makes sense, they crave salt because they're hyponatremic. So workup, you want to get CMP, CBC, get thyroid tests, prolactin levels, and you can get autoantibody testing as needed. You should, and this I didn't put on here, but you should probably get a chest x-ray if you suspect Addison's disease or some kind of adrenal insufficiency, because tuberculosis can infiltrate into the adrenals and cause adrenal failure that way. We don't see TB in the US that much, so not really something that I think of personally a whole lot. And then CT abdomen may be useful as well. You can look for atrophy of the adrenals. That would point to Addison's. You can also look for calcification of the adrenals. That would point towards things like TB. With your labs, you're going to see hyponatremia, hyperkalemia, eosinophilia, which would be an indication of the autoimmune nature of this disorder, and then hypercalcemia can be seen in some cases. Importantly, for diagnosis, you get plasma cortisol levels. Those are, of course, going to be low because we have adrenal insufficiency. And then ACTH stimulation test will nail down your diagnosis. What would the ACTH stimulation test show you? Would the cortisol levels respond or not? So ACTH stimulates what? The adrenals. And are the adrenals working here? No. So you're not going to get an increase in cortisol as if you were to inject any of us, if we don't have Addison's disease with ACTH, your cortisol levels would increase because it stimulates your adrenals. Patients with Addison's, their adrenals don't work. You give them ACTH, no change. The treatment for Addison's disease is going to be replacement with hydrocortisone, usually about 15 to 20 milligrams. Divide that up 3 times a day. Some physicians recommend weight adjusting the hydrocortisone. I don't really have an opinion one way or another. Important to bear in mind, you may be asked this on the test, that if the patient is undergoing any kind of physiologic stress, so things like surgery, trauma, infection, any kind of illness, you want to give them extra steroids to prevent acute adrenal crisis, because normally our cortisol levels go up during, if you have pneumonia or you have mono or you're getting an appendectomy or you get hit by a car, your cortisol levels go up. Well, these patients can't do that kind of self-regulation, and so you need to give them extra cortisol, hydrocortisone, to prevent acute adrenal crisis. Okay, so this is that sort of hyperpigmentation that you see particularly along the knuckles and the joints here. You can also see it along the knees and elbows. Okay, question 6 gives us a 24-year-old woman presenting to the ER complaining of shortness of breath over the last 4 hours. She's otherwise healthy and works as a yoga instructor at a fitness club. Her medications include ethinylestradiol, levonorgestrel for contraception. She denies alcohol and illicit drug use, but does smoke about a pack per week and has been trying to cut down. She's monogamous with her husband of 2 years. Vitals 130/90, heart rate 120, respirations 32, temperature 97.9, saturation 90%. Lungs are clear to auscultation. Heart rate is fast but no murmurs. Remainder of the physical exam is unremarkable. Which of the following is the best next step in the management of this patient? A. Retaplase. B. Bolus of normal saline. C. Coumadin. D. Heparin. Or E. Aspirin. All right, the answer to this one is D. Heparin. So what's our presumptive diagnosis in this patient? Presumptive diagnosis here is pulmonary embolism. Why pulmonary embolism? Well, she's got risk factors and she's got symptoms. What are her risk factors? What are the risk factors for pulmonary embolism? Well, they're the same risk factors as for DVT. And in this patient, in a young patient, really the big risk factors are going to be oral contraceptives, smoking, hypercoagulability issues. And so this patient, you put together this very bad combination of oral contraceptives and smoking, her risk for DVT, pulmonary embolism, goes up significantly. Regardless of her keeping healthy, being a yoga instructor, not drinking, not doing drugs, the fact that she smokes and is on oral contraceptives is a double whammy. So you put that together with her symptoms. Her symptoms include poor saturation. Did I put chest pain? No. Okay, so she may have chest pain, she might not. That's not always present. She may have fever, may not. But there's poor saturation, shortness of breath, increased respiratory rate, but the lungs are clear to auscultation, meaning there's no pneumonia or anything going on here. So she simply has an increase in dead space in her lungs. You're not perfusing the lungs. If you're not perfusing the lungs aren't perfusing the blood. And so she's got decreased saturation for that purpose. All right, so the presumptive diagnosis here is pulmonary embolism. Pulmonary emboli usually arise from thrombus formation in the deep venous circulation of the lower extremities. And as I mentioned, the risk factors include venous stasis, as well as hypercoagulable states, immobilization, pregnancy, oral contraceptives, estrogen replacement, and I suppose surgery and trauma, but that's probably also due to the immobilization as well. So why not A? Okay, this is a big deal. So this is somewhat controversial. So thrombolytics, and what Retaplase is it's tissue plasminogen activator. It breaks up clots. You're only going to use those in patients who have pulmonary embolism who are also hemodynamically unstable. This patient is hemodynamically stable. 130/90, great. Okay, if she came in, however, with a blood pressure of 80/60, we'd be giving her IV fluids and Retaplase. Okay, so you only are going to use thrombolytics in a patient who, in the setting of pulmonary embolism, who is hemodynamically unstable and also doesn't have a high bleeding risk. So because this patient is hemodynamically stable, we're not going to do that. Thrombolytics have only been shown to have beneficial effects in patients who have pulmonary embolism and who are hemodynamically unstable. With hemodynamically stable patients, we don't give Retaplace or thrombolytics. But this is controversial and it's the subject of a lot of studies. But as of this moment, no Retaplace for pulmonary embolism if they're hemodynamically stable. IV fluids would be great in this patient if she were hemodynamically unstable. It'd probably be the very first thing you would do in the ER or as you're getting the thrombolytics ready if she were hemodynamically unstable. But she doesn't need it at this point. She's 130/90. Her hemodynamics are just fine. Okay, why not Coumadin? So Coumadin is something that you would want to give this patient in the long term to anticoagulate her, and she's going to need long-term anticoagulants. But in the short term, Coumadin would actually promote coagulation. Remember, it can cause that skin necrosis for that fact. So we don't want to give Coumadin right away. We would give her Coumadin after being on heparin for a few days, but we don't want to give Coumadin right away. And then aspirin, it inhibits platelet aggregation. It's good for preventing venous thromboembolism, but an anticoagulant is going to be needed in the presence of active VTE. So we're going to give her heparin. So pulmonary embolism, we already kind of talked about what that is. Any risk factor for venous thromboembolism is a risk factor for pulmonary embolism. So anything that can cause DVT can cause PE because PE typically comes from DVT. The symptoms can include tachycardia, which we saw in this patient, I believe, yes, 120. Tachypnea, which we did see in this patient. Presence of signs consistent with DVT. So things like calf swelling, increased calf diameter. Usually we do diameters of both calves to check to see if there's a difference. And then Homan sign, which in Homan sign you have the patient, well, you actually just do this passively. You do dorsiflexion of the foot, and that should cause a pain in that affected leg. So for other things that you might see would be rails would come up about half the time. Fever, only about 43% of patients with PE will have fever. And then an accentuated heart sound is present in about, second heart sound is present in about half of cases as well. Clinical signs that suggest thrombophlebitis are only present in about 32% of cases. And so not having signs of DVT does not rule out a pulmonary embolus, as contrary to a lot of what some people might think. Okay, so what do we do for diagnosis? You're going to get an ultrasound of the calf to look for DVT. If you do see a DVT, you pretty much have your diagnosis nailed down right there. If there's moderate to low probability, and I'll show you how we determine moderate or low probability, you will get a D-dimer to rule it out. A low D-dimer or a normal D-dimer will rule out pulmonary embolism. It's very good at ruling out pulmonary embolism, but it's not very good at ruling it in, diagnosing it. Okay. The treatment is heparin or low molecular weight heparin. As mentioned, unstable patients can get Retaplace and fluids. So this is the Wells score that we use for assessing risk for DVT. You can see clinically suspected DVT would get 3 points. That's pretty easy right there. So if you have a swollen calf, a positive Homan sign, that would get you 3 points. Alternative diagnosis, less likely than PE, is 3 points. Tachycardia is 1.5 points. So that's pretty simple. Heart rate over 100, get 1.5 points. Immobilization for more than 3 days or surgery in the last 4 weeks gets 1.5 points. If they've had a personal history of DVT or PE, that's 1.5 points. Hemoptysis is 1 point. Current malignancy is 1 point. Remember, having malignancy increases your coagulability. And so the way we interpret that is placing them into the high, moderate, and low probability categories using 2 and 6 as our cutoffs. Okay. Question 7. A 20-year-old male presents to the ED complaining of fever, malaise, cough, and fatigue over the last 4 days. There is no medical record on this patient, but he says that he is otherwise in good health. He does not take any medications. He's currently unemployed and lives with his parents. He denies smoking, alcohol, and drug use. Vitals 100/70, heart rate 95, respirations 14, temperature 101.9, saturation 97. Physical exam is significant for a holosystolic murmur on the left sternal border, which increases with inspiration. Lungs are clear to auscultation. Chest x-ray reveals bilateral pulmonary infiltrates. Echocardiogram reveals a dilated right atrium and right ventricle with an oscillating vegetation attached to the anterior tricuspid valve leaflet. The left side of the heart is normal. Which of the following is the most likely explanation of these findings? Is it A, congenital heart disease, B, rheumatic fever, C, illicit drug use and Staph aureus endocarditis, D, systemic lupus erythematosus, or E, Candida albicans endocarditis? And the answer here is, ta-da, illicit drug use and Staph aureus endocarditis. Well, Dr. Bowen, I thought you said he wasn't using drugs. Well, a lot of patients say they're not using drugs, especially young patients who live with their parents who might kick them out. So you can't always believe a patient when they come in and tell you they're not using drugs. And if it walks like a duck, talks like a duck, quacks like a duck, it's a duck. And this patient has all the signs of tricuspid valve compromise, and so he is more than likely using drugs. Okay, IV drug use is the most common cause of tricuspid valve compromise among young patients in the United States. And so you would want to get a urine tox screen in addition to this just to confirm that, okay, yeah, he's shooting up heroin. But it's pretty clear, just based on the echocardiogram, that something's wrong with his tricuspid valve. I mean, you listen to him, you listen to his heart, and you hear that there is a murmur in the region that we would expect a tricuspid valve murmur to show up in. And so you get a new murmur in a young person, you want to get an echocardiogram, and indeed we see this vegetation on the tricuspid valve. And so we are going to narrow this down to pretty much drug use and drug use, because that's really the only way that tricuspid valve issues show up in young, healthy people. Now, one of the ones that you may have looked at, and if you picked it, you did very good, but you have to take in mind the consideration of this patient, is Candida albicans endocarditis. This one, unlike the other three, could theoretically cause tricuspid valve dysfunction in this patient, but for the fact that this patient is not immunocompromised. So Candida endocarditis could cause tricuspid valve dysfunction in immunocompromised patients, as well as patients with AIDS or long-term indwelling catheter placement. It could theoretically happen in IV drug use. That's one of the much less common causes, but note here that I put illicit drug use and Staph aureus endocarditis. Staph aureus endocarditis is far and away the most common pathogen when you're using illicit drugs, when you're using needles. Okay? So this is not Candida albicans endocarditis, but if you picked it, good try. Congenital heart disease, the tricuspid valve is very rarely affected with congenital heart disease, so that's not it. Rheumatic fever, not something we commonly see in the US, and even then, it usually affects the left side of the heart, the mitral and aortic valves. And then lupus, that can cause vegetations on the valve, but it's not going to cause septic. Not going to cause septic vegetations. They're going to be aseptic vegetations. And this guy has a fever. Okay, he's got something bacterial going on in his blood. And that's that Staph aureus around. So that with lupus, they do get those vegetations, but they're aseptic vegetations, and those are known as Libman-Sachs vegetations from Libman-Sachs endocarditis. And those are made out of fibrin, neutrophils, lymphocytes, histiocytes. They're not made out of any kind of bacterial products. And furthermore, Libman-Sachs typically shows up on the mitral valve, not the tricuspid valve. So you want to suspect tricuspid valve endocarditis anytime you have a patient with known or suspected IV drug use, but also patients who have immunocompromised status who show up with fever and a new murmur. The murmur with tricuspid valve endocarditis is going to be holosystolic, and it will be appreciated on the left sternal border. To diagnose this, and really anytime you have a patient with a new murmur, you want to get an echocardiogram. And that should be followed with blood cultures before starting treatment. Very important. So you've got to do this beforehand. If you start giving antibiotics and then you do a blood culture, well, you're screwed. So you need to you do your echocardiogram, make a presumptive diagnosis of tricuspid valve endocarditis, and then get your blood cultures, and then start giving antibiotics. Now, in the initial term, the antibiotics that you give are going to be broad spectrum because we don't know what we're fighting. It's probably Staph aureus, but we don't know. So we give broad spectrum antibiotics, vancomycin or nafcillin and gentamicin. So vancomycin or nafcillin and gentamicin. Once you get your blood cultures back, you know the causative agent, then you can monkey around with your antibiotics. Usually you'll have your friendly infectious disease specialist who will tell you exactly what to use and make your life a lot easier. Okay, so I didn't put this on here, but a mnemonic for endocarditis is Junior No Fame, JRNOFAME. J for Janeway lesions, which are those lesions on the palms and soles. R for Roth spots. N for nail bed hemorrhages or splinter hemorrhages. O for Osler's nodes. F for fever. A for anemia. M for murmur. And E for emboli. So I did a lecture on endocarditis. You can go back and refer to that if you want to hear my voice talking about endocarditis to you for half an hour. The Duke criteria are commonly used for endocarditis. You get a list of major criteria, a list of minor criteria, and basically if you have 2 of the major criteria, 1 major and 3 minor, or 5 minors, then it's considered definite endocarditis. I wouldn't memorize this for the test, but I would memorize the part that tells you what the typical symptoms are. So these vegetations that you see on echo, a new murmur, history of IV drug use, a fever, and then these things that I've never seen personally in real life, but Janeway lesions, Roth spots, Osler's nodes, stuff that you need to know for the test, but you'll probably never get to use in practice. I don't know. Maybe you guys see more endocarditis than I do. I don't ever see it. Okay, so let's go on then to, this is what this patient had. So our patient had 2 majors and 2 minors, so he definitely had endocarditis. He had the new murmur, he had the vegetations on echo, so that's enough to satisfy the Duke criteria. Okay, question 8 gives us a 37-year-old woman presenting to the ED complaining of severe chest pain over the last 2 hours. This is the 3rd episode she's had in the last week, but the episodes would resolve in 15 or 20 minutes. The pain is rated as a +9 out of 10 and is described as crushing and is substernal in location. It radiates to her left shoulder. It is not relieved by rest. She is otherwise healthy and takes no medications. She denies alcohol, tobacco, and illicit drug use and exercises regularly. Vitals are stable and within normal limits. EKG is performed, and this is what you see. Come on. There we go. Okay, so this is what you see. You can pause it if you want to look at this a little longer. So, cardiac enzymes are done. Those are within normal limits. The patient is admitted and taken for coronary angiography, which reveals pristine arteries and no sign of stenosis. Ergonavine is administered and elicits chest pain, and similar EKG findings are observed, similar to what you just saw. Which of the following is the most likely diagnosis in this patient? A. ST elevation myocardial infarction, or STEMI. B. Unstable angina. C. Stable angina. D. Prinzmetal's angina. Or E. Cocaine abuse. All right. So the answer to this question is Prinzmetal's angina. So why is this Prinzmetal's angina? Just off the bat, you should we never want to say, well, this patient could never have a heart attack, because anybody could have a heart attack. But on a test question, when you have a patient with everything that looks like a heart attack and sounds like a heart attack, and if this was a 77-year-old woman, you would think definite heart attack. They come in, everything looks like a heart attack, they get an EKG, and they have ST elevation, as we saw here. Look, ST elevation all over the place. 1, 4, 5, 6, 3, 2, ST elevation. So they come in with all these things. They have ST elevation. They have all the chest pain you associate with heart attack. But then they're young. Or the cardiac enzymes are normal. Or they get coronary angiogram and their arteries are clean as a whistle. That is Prinzmetal's angina. Okay, Prinzmetal's angina is everything that a heart attack has except for elevated cardiac enzymes and issues with stenosis of the arteries on angiogram. So with Prinzmetal's angina, you typically don't have any like blockage of your coronary arteries. But otherwise, it looks just like a heart attack, and these patients think they're having a heart attack, and they should because all the symptoms are there. And then you might get an EKG and freak out and think my 37-year-old woman here is having a heart attack. But that's why you always get cardiac enzymes when you suspect that a patient may be having a heart attack. Now, if this were an older patient and they had STEMI, they are probably having a heart attack. But when it's a 37-year-old woman who has ST elevation, it's possible she's having Prinzmetal's angina, especially because she's had previous episodes, but then she turned out to be totally fine. So, as mentioned, with STEMI will result in a similar set of symptoms, but the symptoms usually will persist. Now, this patient's had these symptoms for the last couple hours. I don't really know why that is, but importantly, STEMI will be associated with atherosclerotic disease when you do your angiogram. Unstable angina, also, like this patient, can get these angina episodes at rest and can also be associated with some ST changes on EKG, but it's not likely in this patient because of two reasons. First of all, she's young. Second of all, her coronary angiogram shows that her arteries are clean. With unstable angina, the arteries will usually be a little gunked up and have some stenosis. And of course, very importantly, we didn't even talk about it, organavine. Now, normally we don't give organavine that often because we don't like to put patients in pain, and there's also some contraindications. But when you give organavine and it elicits chest pain and it causes ST elevation on EKG, then that's a diagnosis of Prinzmetal's angina right there. Stable angina is totally different. You're going to have similar symptoms, but the patient would say it's relieved by rest. I sit down, it goes away. I exercise, it comes on, I sit down, it goes away. And then stable angina too will also usually show some degree of stenosis, usually not that much though, not as much as unstable or if she were to have had a heart attack. Furthermore, her age just kind of makes any kind of atherosclerotic angina to be less likely. And then cocaine abuse. Now, cocaine can trigger Prinzmetal's angina, but we have no reason to suspect that she's abusing cocaine, and most patients with Prinzmetal's angina don't use cocaine. But if she has Prinzmetal's angina and she ever tries cocaine, she's probably in for a very, very bad day. So Prinzmetal's angina arises from coronary artery vasospasm. The artery spasms, it temporarily cuts off blood flow to the myocardium, and that's what results in that characteristic pain, which is very, very, very similar to what you get with a heart attack. And these patients will often think they're having a heart attack, and it stands to reason because they are pretty much caused by the same pathogenesis. The only difference is with Prinzmetal's angina, it will reverse itself when the artery relaxes. With a heart attack, it's caused by an obstruction, and that's not going to relieve itself. So classically, Prinzmetal's angina affects younger women. It tends to be at rest. A lot of times the cases will show up in the morning. Not really exactly sure why that is, but you'll see that come up. Younger patients. So these are younger patients, usually 30s, 40s, 50s. Not the age range that you expect to see heart attacks in. But you always have to assume that this is a heart attack. Okay, so when these patients come in and they have all the symptoms that are classic of a heart attack, you're not going to say, oh, well, you're 40, you're not having a heart attack, you have Prinzmetal's angina, and I'm just going to give you nitrates. It doesn't work that way. So if a patient comes in, they have all the symptoms of a heart attack, and you get an EKG, and they have STEMI, or what you think to be STEMI, they have ST elevation, then you're going to be assuming that they're having an MI, and you're going to give them all the things that you would give a patient with an MI: aspirin, beta blockers, oxygen, nitrates, morphine. But what you'll then do is you'll send these patients off for angiogram, and of course you'll also get cardiac enzymes. And combining what you find with cardiac enzymes, which will be negative, they'll never be negative in a true heart attack, and what you find with angiogram, which will be clean arteries, you can pretty much make your diagnosis right there of Prinzmetal's angina. Like I said, you can give ergonavine during the angiogram, and you can see if the patient has a response to that. That's not done that often anymore, just because with cardiac enzymes, if they're negative, we can pretty much rule out a heart attack and make the diagnosis of Prinzmetal's angina, and also not having dirty arteries. Prinzmetal's angina is treated with calcium channel blockers and long-acting nitrates. So something like amlodipine and then a long-acting nitrate. Beta blockers are not given for Prinzmetal's angina. That's important. So do not give beta blockers with Prinzmetal's angina. They don't help whatsoever. Beta blockers are wonderful for patients who have had heart attacks. They improve survival. Prinzmetal's angina, it's not going to do anything for them. As a matter of fact, what we've found is that it may actually make their episodes more frequent and worse. So we don't want to give them beta blockers, calcium channel blockers, and nitrates for Prinzmetal's angina. Okay, question 9 gives us a 29-year-old guy coming in and happens to have gotten a chest x-ray, and we found a solitary nodule. He's otherwise healthy, he's not on any medications, denies drug and alcohol use, he smokes 1 pack per day for the last 10 years. This chest x-ray shows us this. Okay, so find your nodule. And then we decide to do a CT on him, and we see this. Okay, this isn't the same patient, but this is the same diagnosis. So, same side. So where's our nodule? You can see it. Okay, so the nodule is located in the right upper lobe, measures approximately 1.7 centimeters in diameter. Which of the following is the most likely diagnosis in this patient? A. Hamartoma, B. Sarcoidosis, C. Bronchogenic carcinoma, D. Secondary tuberculosis or reactivated tuberculosis, or E. Pulmonary abscess. The answer here is A. Hamartoma. So the presumptive diagnosis in this patient is a hamartoma, primarily because of the way that this nodule appears, but mostly because of his age. So we don't expect a 29-year-old man, even a 29-year-old smoker, to show up with a bronchogenic carcinoma, or really any lung cancer for that matter. Now, of course, it's always a possibility, but this question is asking you which of the following is the most likely diagnosis. And when you have a patient who has, as this guy does, a nice smooth nodule with a little bit of calcification, the first thing you need to think of is a hamartoma. Okay, so hamartomas classically show up with these nice smooth borders and this calcification. We call this a popcorn-like pattern. Kind of looks like a little piece of popcorn, like popped popcorn here. Notably, there's no cavitations. The size, give or take, maybe a couple centimeters. It's hard to really tell exactly because here you're only getting 1 dimension on either side here, or 2 dimensions. So it's hard to tell exactly, but it's really no bigger than a couple centimeters. And that's typically the size of hamartomas. So you have 5 choices here, hamartoma obviously being the correct one. Why not sarcoidosis? Sarcoidosis very frequently affects the lungs. It can show up as a solitary nodule, but more commonly, in the vast majority of cases, sarcoidosis is diffuse multinodular infiltrates. Often also with sarcoidosis, there is also hilar lymphadenopathy. We didn't see that in this patient. His hilar nodes are totally normal. Now with sarcoidosis, typically these patients will not be otherwise healthy. A lot of these patients will have symptoms of restrictive lung disease. Bronchogenic carcinoma also commonly presents as a peripheral solitary nodule, as this patient did, but these patients will tend to be older and have a much more extensive smoking history. We certainly cannot rule out bronchogenic carcinoma in this patient just by clinical picture and radiographs alone, but it's very unlikely just because of his age. Okay? 29-year-olds don't get lung cancer like that, who are otherwise healthy, even if they smoke. And he's been smoking for 10 years, but you're going to see lung cancer in 55, 60, 65-year-old patients who have a 30, 40 pack year smoking history. In that case, this picture would be would be pointing much more likely towards a bronchogenic carcinoma. But also the other thing that points away towards bronchogenic carcinoma and towards hamartoma is that there's calcification. And calcification is not going to show up in bronchogenic carcinoma. So it looks similar to this, but it'll be an older patient and there won't be any calcification. Secondary tuberculosis, also like this, has a tendency to affect the upper lobes, but it too will be more multinodular and be more of an infiltrating pattern as opposed to a solitary pulmonary nodule. These patients will also tend to have weight loss and malaise and cough, and usually in the US they'll have a history of foreign travel. Tuberculosis is just not very common in the United States anymore like it used to be, and there goes my dog again. All right, so what about E, pulmonary abscess? So pulmonary abscesses also tend to show up with solitary nodule, but there's going to be very little calcification, if any. And usually with an abscess, you're going to see a cavitation with an air fluid level, and this is totally solid. So that's not the case in this patient. So with a solitary pulmonary nodule, what we do is we look at the size of it. Usually they sit between 8 and 30 millimeters in diameter. There's slightly different guidelines if you're smaller than that. But what we're going to do is we're going to determine the probability of cancer. And we base that on risk factors, patient age, smoking status, whether or not they've had a history of cancer. Obviously, you can have a solitary metastasis, not very common, but that is a possibility. So if they have a history of cancer, you need to consider that. And then the size, morphology, and location of the lesion. This patient has very few risk factors for actual primary lung cancer. So he would fall in this low probability of cancer. We would just follow him up with CT at 3, 6, 12, and 24 months. So we're not going to be going in and biopsying this guy. So the radiologic feature suggestive of a benign lesion with a solitary pulmonary nodule would be less than 5 millimeters, not the case in this guy. Smooth border, yes. Dense, yes. Positive calcification, yes. Doubling time or less than 1 month or more than 1 year, we don't know. That's why we're going to follow him up. With a malignant, it's usually bigger. There's an irregular border, not a smooth border. The appearance will be non-solid or ground glass. There's no calcification, or if there is, it's going to be eccentric. And then the doubling time sits in that sweet spot of 1 month to a year. So if it's growing really quickly, or if it's not growing hardly at all, that point's benign. If it's doubling every month to a year, in that range, that is more suggestive of a malignant lesion. Then, of course, there's the risk factors, and that's going to be important when you approach these questions on boards. So if there's a previous history of malignancy, if it's spiculated, kind of like little spikes coming out on the edges of the lesion, if the patient is a current or past smoker, if it's located in the upper lung areas, if it's a larger diameter, or if the patient is old. I would say out of all of these, you really got to look at old age and smoking history. Those are the two big ones. This patient is just not that old. We don't see lung cancer in people in their 20s, regardless of whether they smoke. So you have to keep that in mind. All right, if I gave you the same patient and he was 69 instead of 29, then you definitely have a higher suspicion of lung cancer, regardless of how everything else looks. The differential is vast for a solitary pulmonary nodule. Things like malignancies, non-small cell, small cell, carcinoma, lymphoma, and also the possibility of a solitary metastasis. Benign things can include hamartoma, as we had in this case. Also, arteriovenous malformations can show up as nodules, quote-unquote nodules, on chest x-ray. Infectious things so like granulomas, tuberculosis, round pneumonia, abscesses. Non-infectious things like amyloidomas, rheumatoid nodules, Wegener's granulomatosis can show up as nodules in the lungs, and then congenital things like bronchogenic cysts. Okay, I think I beat that horse enough. Question 10. All right, last question. So with this patient, we have a 52-year-old woman presenting to the clinic complaining of a changing mole on her neck. It has been there for the last several years, but only recently has it become darker and seems to have grown. Red flag. There is no significant past medical history and she takes no medications. Physical exam is remarkable for a 1.2 centimeter reddish-black elevated lesion with irregular edges. Wide excision reveals a malignant neoplasm with 3.5 millimeters depth of invasion. Which of the following tumor markers is most likely to be positive? Oh, I did it again, right? USMLE loves to do this. They give you an answer or a question, and you're like, I know it, and then they give you the stem, and it's like, oh, back to USMLE step 1, right? So you got to know these tumor markers. It's going to come up on step 2 and step 3. Why do you need to know these? Because you'll order tumor marker levels to determine whether or not a patient has a certain cancer, or it helps you at least in your diagnosis. So in this case, you're not going to get a serum level of this marker, but you will stain for it on histology. You want to know this tumor marker, which is associated with this cancer. So what is the answer? Well, here's the tumor. But what's the answer? It's S100. So S100 is the tumor marker that's going to be associated with malignant melanoma. And that's what this patient has, malignant melanoma. That was relatively straightforward. But you need to know the tumor marker. And the tumor marker is S100. And S100 is also associated with another tumor. And do you know what that one is? They're the astrocytomas, which happen in the brain. So what about these other ones? So CA19-9, what's that associated with? Gotta know this. Pancreatic cancer. CA19-9, pancreatic cancer. How about CA125? What's this one associated with? It's not part of internal medicine. It's part of gynecology. Gotta know this one too. Ovarian cancer. How about HCG? Another one associated with gynecologic stuff. Gestational trophoblastic disease. Remember that thing where you think you get pregnant, but you're not pregnant, you're just full of grapes? Gestational trophoblastic disease. Choriocarcinoma, also you see with HCG, and then some of the germ cell tumors. And then what about AFP? Alpha-fetoprotein. Germ cell tumors, but what's the big one? Liver cancer, hepatic cellular carcinoma, hepatocellular carcinoma. Okay, so it's pretty straightforward with this. If you know the marker, the whole question was easy, but it's knowing the marker, which is the hard part. And these markers that I give you here are ones you definitely want to know. There's some other ones, but these ones you definitely want to know. So just as an aside, for melanoma, which you will want to take with you and put it in your pocket for the test, is the ABCDE mnemonic. And that really is useful. It's also something you can tell your patients, because this is pretty easy for people to remember too. I mean, regular people, not weird people like us. Okay, so A stands for asymmetrical. So non-cancerous lesions tend to be symmetrical. If you draw a line down the middle, it looks the same on both sides. Borders. So you see here, irregular borders. It's not smooth borders, they're irregular borders. Okay, kind of curving around there. C, multicolored. I like to think like the American flag, red, white, and blue. Not just brown, but there's parts of red, and then there's kind of this bluish, and looks kind of black, but really dark blue areas. Sometimes they can get white too. Then diameter, more than half a centimeter. If it's smaller than half a centimeter, points towards benign. Bigger than half a centimeter, points more towards malignant. I tell patients about the size of a pencil eraser. If it's any bigger than that, get it checked out right away. If it's any smaller than that, look for the other things, but you can, sort of keep an eye on it. Don't need to panic. And then E, this one's probably most important, evolving. If it's getting bigger, that's a problem. Okay, so these melanomas, they tend to start out as just a regular old mole. Maybe you've had it for a long time, but what happens is they get bigger. They get horizontally, they get bigger, so the size gets bigger, and then after a while, they start to get deeper, or they might elevate. So you might start with kind of a flat mole and then it starts to elevate. But the problem is not that it's elevating, the problem is that it's descending and it gets deeper into the tissue. And survival and prognosis is directly associated with the depth of invasion. So the deeper it goes, the worse the prognosis. All right, so the tumor marker, as mentioned, is S100. Got to know that for the test. You're not going to be getting serum levels of S100, but you need to know that S100 is what they stain for when they do the histology. And then management is going to be excision with wide margins. And the unfortunate thing is, there are chemotherapeutics, but they're not quite as successful as we want them to be yet. So the mainstay of melanoma treatment is still surgical excision, and that's the reason why the depth of invasion is so closely correlated with prognosis, because there's not really anything systemic we can do effectively for melanoma. So if you can't take the whole cancer out, you're in a really tight situation. So the management is excision with wide margins, followed by very close surveillance. Chemotherapy and radiation may be used, but they're not tremendously successful. Okay, and that's all I've got for you on these questions. Thank you for watching, and I will see you in the future.